Thank you for the acceptance of our manuscript, Risk of Colorectal Cancer in Chronic Liver Diseases, a Systematic Review and Meta-Analysis in Gastrointestinal Endoscopy. I am Atsushi Sakuraba of the University of Chicago Medicine, the senior author of this study, and this is Yuga Komaki, the first author of this study. It is our great pleasure to present the results of our study in the author interview. Yuga, please go ahead and introduce the results of our study.
Colorectal cancer is one of the leading causes of death throughout the world. It is the third most common cancer diagnosis in males and females in the United States. Its risk is increased in certain patient populations such as hereditary non-polyposis colorectal cancer, inflammatory bowel disease, those with a family history of colorectal cancer, and African Americans. Among various liver diseases, primary sclerosing cholangitis is known to have a very elevated risk of colorectal cancer, which is mainly attributed due to the concurrence of inflammatory bowel disease. But the risk of colorectal cancer in PSC patients compared to the general population is unclear. Furthermore, it remains largely unknown whether patients with other chronic liver diseases are at risk of colorectal cancer. Exposure to immunosuppressive agents following transplantation is known to increase the risk of post-transplant malignancies, but the risk of colorectal cancer after liver transplantation remains unclear. We performed a systematic review and meta-analysis to assess the risk of colorectal cancer in patients with chronic liver diseases before and after liver transplantation. We set PubMed, Google Scholar, Scopus, Embase, and Cochrane database for studies assessing the risk of colorectal cancer in chronic liver diseases. The primary outcome was the pooled risk of colorectal cancer among studies that reported the risk as standardized incidence rates. Analyses were done separately for pre- and post-transplant patients. Data on PSC was analyzed separately due to its known risk for colorectal cancer. As shown in Figure 1, we identified 172,138 citations through literature sets. After screening of the studies, 50 full-text articles, including 55,991 patients that reported the SIR or incidence rate with patient years of colorectal cancer in chronic liver diseases were identified. For SIR, 4 studies reported included non-transplanted hepatitis and cirrhotic patients. 3 studies included only PSC patients, and 10 studies included post-transplant patients. Figure 2a shows the meta-analysis of the risk of colorectal cancer reported as SIR among patients with non-transplanted hepatitis and cirrhosis. The pooled SIR was 2.06, demonstrating that patients with hepatitis and cirrhosis had a 2-fold increased risk of colorectal cancer. There was moderate heterogeneity, and we undertook meta-regulation to set the causes. As shown Figure 2b, there was a strong positive trend for correlation between the age of the subject and the risk of colorectal cancer. Figure 2c shows the funnel plot, which showed no small study effects or publication bias. Figure 3a is the meta-analysis of the risk of colorectal cancer reported as SIR among patients with PSC. The pooled SIR of the 3 studies was 6.7, demonstrating a significantly elevated risk of colorectal cancer compared to the general population. There was moderate heterogeneity, which appeared to be due to the difference between the power of studies. As we showed in Figure 3b, there were no small study effects or publication bias. Figure 4a shows the meta-analysis of the risk of colorectal cancer reported as SIR among post-liver transplant patients. The pooled SIR was 2.16, showing a significantly increased risk of colorectal cancer. There was moderate heterogeneity, and there was a correlation between the population of autoimmune-related liver diseases and the risk of colorectal cancer. Our results suggest that the increased risk of colorectal cancer in post-transplant patients is more prominent in those with autoimmune-related liver diseases. However, even in the absence of autoimmune-related liver diseases, there appeared to be a twofold increased risk. As shown in Figure 4c, there were no small study effects or publication bias. Based on the result of our study, we proposed that patients with chronic hepatitis and cirrhosis who have a twofold increased risk of colorectal cancer require a screening colonoscopy every 5 years, as opposed to the 10-year interval in the general population. Patients undergoing liver transplant should have a colonoscopy prior to the transplant and subsequently at 5-year intervals, as they have a persistently elevated risk of colorectal cancer. The six-fold increased risk of colorectal cancer in PSC patients justified the present recommendation of annual surveillance colonoscopy that should be continued after transplant. In conclusion, this systematic review and meta-analysis shows that chronic liver diseases are associated with increased risk of colorectal cancer compared to the general population. Our results indicated that patients were at risk regardless of whether they underwent transplant or not. Further studies are needed, but strict surveillance for colorectal cancer is warranted in patients with chronic liver diseases.